anytime you're going to have a comprehensive discussion about crown and bridge, you're going to have to start with material selection, of course. And when I graduated from dental school in 1988, it was pretty simple. There was two choices. There was PFMs and there was cast gold, and that was it. And where I went to school at the University of the Pacific back in 1988, we had to do 26 crowns to be able to graduate, and all 26 crowns that I did were PFMs. It was crazy. It was like, well, cast gold was already kind of on its way out. The only problem was for the California State Board, I had to do a cast gold crown. Never a good idea to do something for the first time on the state boards. Pretty nerve-wracking, but the shift had already started to take place. So when my dad, also a dentist, when he was in dental school, everything they did was cast gold and some porcelain jackets on anterior teeth. And then as he was graduating towards the end of his dental school career, the PFM came in. And then as we saw it, kind of the PFM ruled the roost, for the next 30, 40 years. It was the dominant restoration. And then we had some other all ceramics tried to come in and make some headway, but the PFM still always held on to it because it was so versatile and it could do so many things. I actually got to do 6 veneers in dental school as well, so they really weren't counted as crowns. That was kind of a special project, but had a very early exposure to doing porcelain veneers. The cements back then were very runny, like the consistency of maple syrup. You put it in the veneer, you had to tilt it the right way or it would all run out, and then you'd have to put more cement in. Feels like a plot by the cement companies, but it's gotten more complicated today in terms of material selection. That's for sure. We have more to choose from, and then we have more subcategories within the broad categories that we have as well. And so for context, maybe a good place to start is to look at what happened at a large laboratory last year. So this is Glidewell Laboratories for 2019. This is the breakdown of just crowns. So bridges aren't in here. Those are different numbers that we'll tackle later. But as we look at these crown numbers, it's broken down into anterior and posterior. And if you start at the top, you can see Bruxer solid zirconia. This is the full strength solid zirconia that we'll talk about more in this module. This is the one that came out in 2009. And you can see in the posterior, it's 76% of the crowns. That's a good, healthy number. But you can see in the anterior, it's 24% of the crowns that are being done in the anterior. And so you're asking yourselves, as we look at these numbers, what is the message that dentists have received and what are dentists thinking? Dentists always love to see what other dentists are prescribing, what they're using, what their preps look like, what their impressions look like. So here's a glimpse into the largest lab in the country who works with dentists in all 50 states. And 24% of the full strength solid zirconia crowns that are being done are on anterior teeth. It's a curious choice because we don't need that much strength in the anterior. The biting forces in the anterior are literally 1/3 of what they are in the posterior when we get to molars. And so dentists obviously fell in love with Bruxer solid zirconia as a posterior material and then started pushing it forward. In fact, when we were originally designing the material, for us it was just for second molars, sometimes first molars, and then it was the dentists of the United States starting to prescribe it on premolars and then working their way to the anterior, and we realized, we need to be able to make this look a little bit prettier if they're going to start prescribing it for, say, teeth 8 and 9, but we don't need that much strength up there. And we're sacrificing aesthetics by doing it up there, and it's also the most difficult restoration to cut off out of all these restorations. I mean, the Bruxer aesthetic and the Emax are like close kind of second and thirds, but very difficult to cut off the solid zirconia as well. So putting it on a front tooth is not really necessary. Is it wrong? No, it's not wrong. And in the right patients, it's a really good idea. Somebody who's got that end-to-end wear where they're incisal edge to incisal edge, they've worn everything down. Maybe they're not going to let you put posterior restorations to open the bite and then be able to restore the anteriors. Solid zirconia, especially the full strength one, is the only material that'll stand up to that kind of beating over time. And so for those indications, that's a good time to use full strength solid zirconia in the anterior, but that's not happening 24% of the time. We don't see that many patients. So it's dentists getting into a habit, if you will, of prescribing the Bruxer solid zirconia, the full strength, the original, and then continuing to do it for the anterior. But we don't need to do that. If we look at the next level down, we've got the Bruxer aesthetic. 33% of the restorations done in the anterior of the crowns were the Bruxer aesthetic. This is a better choice for an anterior tooth. It's not as strong, but we don't need all the strength of the full strength solid zirconia in the anterior, but it is more translucent, which is nice. And so we get a better aesthetic result. But if you look at the posterior crowns, 6% of the posterior crowns were done with the Bruxer aesthetic. Why would you do that? I can't really think of a good reason to do it unless you're working on someone like Julia Roberts who smiles and you can see her second and third molars, maybe something crazy like that. But again, I think it's dentists getting in a habit of liking how a translucent zirconia like Bruxer aesthetic looks in the anterior and then saying, oh yeah, let's use that in the posterior, but it's missing something. It's missing the transformational toughening that we have with the full strength Bruxer solid zirconia. And when we go deeper into zirconias in this module, we'll talk about that, but you can't get more translucency on a crown without giving up something. So we give up some flexural strength by going to the more translucent material, which is fine because it's for an anterior crown. But when we put those in the posterior, like these 6% of the crowns are, that's where we have an issue all of a sudden, because now we've seen in the CR studies that Gordon and Rella are doing on Emax and zirconia that these are the crowns that sometimes are breaking when dentists go to seat them. So as a rule, I don't do translucent zirconias like Bruxer aesthetic or other ones, and we'll talk about these categories of materials, the 4Ys and 5Y zirconias when we get there. But as a rule, I'm not using those in the posterior. I never would. I mean, again, even if it was Julia Roberts, I think I'd talk her into the full strength 3Y material. The next material down, IPS Emax, that's a lithium disilicate. You can see 28% of the anterior crowns done at the lab were with Emax. That's my personal favorite to use in anteriors and on premolars as well. If you had to come up with the material that was kind of the perfect mix of flexural strength and aesthetic nature or translucency, Emax is pretty darn close. Doesn't really have the flexural strength as you'll see later for molars unless it's bonded into place and you're definitely sure that you've reduced enough, and that's a big issue with dentists is making sure they reduce enough in the posterior. So 8% of the crowns that you see in the posterior came through the lab were Emax, and again, that's fine if you reduce enough. When we get to the tooth preparation module, I'll share with you the depth cut base method that I use to make sure that I have enough room. And then you also need to adhesively bond Emax restorations on molars into place, because when you do that, you increase the fracture toughness of the material. Now, this isn't true for zirconia. It doesn't matter whether you cement or bond zirconia on a molar. It doesn't increase the fracture toughness, but it increases the retention of the crown on the preparation, of course, which is important. But with Emax, you can actually influence the fracture toughness. So if you bond an Emax crown on a molar, it's harder to fracture that crown than if you cement that Emax on that molar. So we're always going to want to adhesively bond Emax on molars, but we can certainly cement Emax in the anterior if you'd rather do that than adhesively bond it. The next product down, clinical zirconia, and this is Glidewell's generic, like lava, for example, if you think of lava. So clinical zirconia is feldspathic porcelain that's fused to a zirconia substructure, and this is really the first bilayered material that we see on this entire list. Everything else has been monolithic to this point, but this is two materials, the feldspathic porcelain fused to the substructure, and you can see 10% of the crowns in the anterior are from this clinical zirconia. And again, that's fine if you like the idea of having a zirconia substructure and having your technician layer the feldspathic porcelain. You can certainly get a more aesthetic restoration with, and a great technician can give you an amazing result with the bi-layered restoration like this. But again, you have to make sure you reduce enough for the technician to use both of those materials. And you also have to know that the feldspathic porcelain on that clinical zirconia crown is the weakest ceramic material that we have out of all our ceramic choices. So if you've got somebody who's broken a restoration before in their mouth, you want to be careful with these, because kind of like with the PFM, It's that feldspathic porcelain on the outside, that's the weak link. It can chip, it can break. The substructure, whether it was metal in a PFM or zirconia in a clinical zirconia crown, those don't break. It's really that layering material that's going to be a problem. So it was 2% of the crowns done in the posterior, and that's fine. That's a nice low number for that. I don't really like bilayered restorations in the posterior. Why would we do a bilayered restoration in the posterior? We have to reduce that much more to get both those materials to fit in than we do if we use a monolithic material. You know, for years we were stuck doing PFMs in the posterior, and we had to reduce enough, or if we didn't, we had to have a metal occlusal or the whole metal lingual sometimes, or whatever we had to do, or they would chip or they would break, and it was difficult. And it was kind of a revolution with solid zirconia in 2009 to be able to start doing a monolithic tooth-colored material in the posterior. And so you can see with PFMs, in 2019 at the biggest lab in the United States, it was 5% of the anterior crowns being done and 5% of the posterior crowns being done. And that's a really low number. My numbers, personal numbers, even lower. I really don't do any single unit PFMs anymore, but I do a fair amount of PFM bridges. And we'll tackle that a little bit later in this module. But we're not throwing away the PFM bridge. And the PFM crown is fine too. It's, for me, just hard to find a compelling reason because of these other materials you see listed here to use PFM as a single unit crown material. But for bridges, it's still got some fantastic properties where it outcompetes solid zirconia bridges, and we'll talk about that a little bit later. And the last material that you see there is poor cast gold, down to 0% in the anterior. I mean, it always was, except for the craze with, wrappers and their grills that existed for a little while. But cast gold's always been at about 0% in the anterior, but only 3% in the posterior. This is the original monolithic material, cast gold, long before Emax and solid zirconia. What can you say bad about cast gold? It's fantastic, but it's ugly in the eyes of 95% of the patients. They just don't like it. And so that number continues to shrink as well. But with the introduction of solid zirconia, I feel a little better about cast gold shrinking, because as you'll see, we can prep solid zirconia, the full strength one, the 3Y, as thin as 0.6 of a millimeter. So we're getting close to what we could do with cast gold. So it's not an exact replacement, but at least it's getting close. So that's what it looks like for crowns. We'll talk about the bridge distribution of materials a little bit later. One other thing that I wanted to hit, another restoration that seems like it needs to be placed on the endangered species list, is the inlay and onlay. And these are disappearing very quickly. And if we look back at the numbers from the lab in 2003, you'll see that 4.3% of the restorations, that was already pretty small compared to when my dad was in dental school, when nearly everything they did pre-PFM was going to be some sort of inlay or onlay or 3/4 cast gold crown. You had to be very creative with the margins. There was miles of margins. The temporaries were harder. So by the time I got to dental school, whatever it was, 25 years after my dad, it was already to the point where we were basically just doing single unit crowns and not too many inlays or onlays. And maybe that was just something at my school around that time, but I did not do an inlay or onlay again till the California State Boards. By the year 2010, that had gone down to 1.5% being inlays and onlays. In 2019, it's 0.4%. So inlays and onlays, sadly, very conservative restorations where we're not just going in and removing all the enamel. It's sad to see, but that era is coming to a close. But they are difficult to temporize. The temporaries want to fall off. Insurance companies could care less about these. So it's a difficult conversation to have with your patient about, oh, I've got this wonderful conservative restoration. It's the one I would do on my mother. This is the one I would have in my own mouth. What's your insurance going to do? Oh, nothing. It's not going to pay. It'll reimburse it like it was a 3-surface composite or something. But if I do grind all the enamel off your crown and grind your tooth down to a nub, as patients like to say, that they will be happy to kick in 50% for. So it's a weird message, to try to tell the patients, oh, your insurance company doesn't care about you, or they do this nice. It's just easier for most dentists to do a crown and put a crown in place. So really the only place I see inlays and onlays today is in the chairside CAD/CAM market. And they're able to do it, and they don't have to have a temporary crown. They're able to put it in the same day. Because they're able to do that and all that convenience factor for the patient, it's a little easier to have that conversation about whether or not the insurance is going to cover it, because it's just this one appointment and it's done and it's bonded into place that day, and that makes it a very nice restoration. So really, unfortunately, in the lab space, inlays and onlays are going the way of the dodo, but they're still alive and well in the chairside CAD/CAM market. All right, so we're going to move on to our next module now, and we're going to take a closer look at those monolithic restorations and how they've affected dentistry.